I know my popularity is getting lower and lower because I have to stop you now. I understand we need more time on this, but I think we have enough to share at the moment. If we can proceed with what we have, we'll appreciate. Table 1 seems to have just started, but we need to stop and continue. So what we'll do, we'll start with, but I really want us to move together. No one is paying attention. Okay. Can okay, which table is ready to go? What you want to hear from your table, what you've discussed at system level. And system could be a facility, it could be the government, it could be an organization where you are currently in that strategic objective. Any examples, any experiences, and any questions that you can pose to the group for discussion. Table 2 seems to be ready.
Yes, table 2 seems ready, including what questions, what you want us to consider as a continent. I mean, it could include up to the challenges of what do you think we are not doing enough? Anything you'd want to pose as a question for us to continue the discussion another time. Just some highlights of what you've discussed. This is number 2. Yeah, just highlights. Highlights of strategic objective number 2. Okay, table 2.
Okay, thank you very much. This is table 2, which was dealing with the second strategic objective. Is it an objective? Anyway, the second area, which is build high reliability health systems and health organizations that protect patients daily from harm. So what we did is we wanted to look at each of those areas in the matrix and just rate, because in this table we have 3 countries represented. We have Kenya, we have Cameroon, and South Africa. So we wanted to see if the various areas cut across in the same way. So we had started with transparency and openness and no blame culture. And what we saw is that in the 3 countries, we decided to rate it. So we had a scoring system where 1 was very poor or poor, 2 was average, and 3 was good. So we looked at transparency and no blame culture, and across the 3 countries, whether private or public, were actually at 1, which was quite poor. So we then looked at what are some of the low-lying fruits, or how can we improve this? And okay, the reasons for this. The reasons was because there seems to be a lot of not sharing data. You know, different facilities, different organizations seem to keep the data to themselves. And this is more so in the private sector. Government are a bit better in that, but in the private sector, you know, we tend to hold, I'm from the private sector, we tend to keep the data to ourselves, yeah? And there's also a lot of blame game, yeah? There isn't openness, so people feel like it's not safe to share what they have. So how can you know, what are some of these low-lying fruits that can lead to improving this? One was to create a safe psychological environment. And how do we do this? You know, we have this data with us, so we can analyze it, we share it out there, we have forums where we can discuss with staff or other stakeholders and share this data and come to conclusions and learn from it. The other was, okay, I can go to, we discussed a bit on good governance. South Africa are doing better than the Cameroon and Kenya. They were at 2, they're at average. And Cameroon and Kenya are at 1, so we are poor on that when it comes to good governance. And we were just touching on how we can improve that, but we didn't exactly finish, so time ran out. But yeah, thank you. So that's where we reached.
Thank you so much, that group. So I think even from that experience, you can also gather the Kenyan and the Cameroon experience. The Kenyan Cameroon experience. We just heard what Dr. Irungu presented earlier, and I think he detailed the policies that we have in the country, but also just tells us that having those policies is not enough, yeah? It has to go down to operationalization of these policies. Yeah, great. Thank you. So any other team that is ready? Great, thank you.
Okay, thank you. This is Team 1, and Team 1 looked into the very first one of the matrix, and that's all about policies to eliminate harm and to improve patient safety. And we all know that QI is all about data. Here on this table, we have 3 countries, Kenya, Nigeria, and Botswana. Kenya scored 4/5. Please, let's clap for Kenya. Nigeria and Botswana scored 3/5. You know, the matrix is 5. There are 5. So, Kenya, well done. Botswana and Nigeria, we are coming after you. Yeah, so it's all about policies. So, do we have these policies in these different countries? You know, and then only Kenya had a separate policy strategy for patient safety. Other countries had it subsumed in different policies, you know, but no separate policy that directs to patient safety. So for those countries that didn't have, what's the potential, what are the low-hanging fruits? And we felt advocacy is key. You know, so we need to advocate to the top level of leadership because they are the ones in charge of policy. So we need to advocate to them why it's important for policies to be in place with respect to keeping our patients safe. And then for those countries that already have policies, how are you implementing them? How are you monitoring those policies and evaluating it? So those are things to look into. So the second matrix there with respect to policies were policies around resource mobilization and things like that. Resources covers human, material, and all that. We all have resources in those countries. The low-hanging fruit to look into with respect to resource mobilization and allocation we felt was a budget. You need a budget, you know, so to drive resource mobilization and allocation. You need to collaborate with your donors, your stakeholders, community, with respect to always having adequate resources. And the next thing with respect to policies were to have protective legislative measures around those. If you don't have a policy, then definitely you can't have the legislative measures around that. So for us, we felt, yes, we need advocacy in that direction as well, and maybe we need a separate charter that deals with having those legislative measures to protect against whatever policies or acts or bills you might have. And then the second to the last one with respect to policies were safety standards, regulations, accreditations. Everybody scored 1 point here. There's no country that does not have one form of accreditation or the other. Now the thing is, again, implementation, you know, how is it funded? Is it independent? and things like that. So we need to use data to leverage and drive these bodies to be more effective. And finally, the World Patient Safety Day. All three countries, Botswana, Kenya, and Nigeria, observes the World Patient Safety Day. Yeah, so it's an opportunity to draw more light on patient safety, focus on it, and all that. And in Nigeria, if I will use my country as I hold the mic as an example, we started in 2019 to begin to observe World Patient Safety Day. And in the public health sector, it's been a yearly event. Even like we are competing with one general hospital is competing with another. We are showing pictures, we are bringing drums out, we are creating, So it's been a positive thing. So the low-hanging fruits and the potential there is to go beyond the fun and all that, to really now start making it grounded and being more impactful. That's the word. Thank you.
Thank you. Thank you. Thank you very much.
Let me give a comment. She said to go beyond the fun. I was with her in last year's World Patient Safety Day celebration somewhere in some country in WHO, and they had pictures. They had nice pictures. So I truly agree. We go beyond the fun as a continent to having meaningful engagement. I guess Dr. Kalandu understands what that means. So who's the next?
Okay.
Oh, here.
Next to you.
Koronko, the surgeon.
Yes, Mr. Chairman, thank you very much. On behalf of Group 3, we are 4 countries represented. We have Nigeria, we have Ghana, and we have Tanzania and Kenya. And by default, we're all Kenyans at this particular moment. We had a task to look at strategic objective number 3, assure the safety of every clinical process. The process that popped up into our mind was surgery. I don't know how it came. I'm a surgeon. Probably I was the center of thinking sometimes. So rain doesn't fall on one roof. We also fallen in the same trap of time. We were able to discuss 3 things, and we will have contribution from all the colleagues if I forget some of the few things. So objective number 3.1 is talking about safety of care. And what came into our mind, it is surgical safety checklists and any other checklist, standard operating procedures, and informed consent. We looked at these things very critically, and we thought that not every countries have the full coverage utilization of WHO surgical safety checklist. In Kenya, urban, yes, it is above 70-90%, and in rural, it is almost below 50%, and some other hospitals, they don't even know what it is. And therefore, towards that, the low-hanging fruit is to advocate for WHO surgical safety checklist at all centers, and at least adopt it as one of the policy and the standard packages for surgical care. Number 2 was about informed consent and quality of care. We thought that low-hanging fruit, we appreciated that in our hospitals, people come with the patient come with their relatives and family members. Unfortunately, they are chased away, and they're allowed only to come during visiting hours. And when surgery comes in, we do not have family rooms in the hospital. The infrastructure doesn't accommodate relatives to stay around, even to receive the bad news or good news that comes from the operating room. And even the patient care in the wards, throughout the process, you find that they are chased away and they're not part and parcel of the care that is provided by the patient. But we are learning from individual contribution that patients are more safe in their relatives' hand than in their staff, because we understaffed so much. And we are given an example that bed sores, for example, prevention of bed sores, a relative can do very well 2-hourly turning than the nurses. And by doing so, probably they can improve the quality of care. But also, relatives, when they're empowered, they can really tell you that you said you'll give pain medication after every 8 hours. It is now 2 hours past the time we need to support, and they can remind the healthcare workers who are very much overwhelmed with the care in the wards. And therefore, our low-hanging fruit at this particular point is to look at how best can we integrate the families into the care of our patient. Number 3 was about medication errors, adverse reactions from medications that patient may have. Here we noted that every country has got Food and Drug Authority that is in charge of looking to the safety of the medications that we give the patient. And that drug authority have developed a form that goes around into many hospitals. In East Africa, they are yellow. I don't know in Nigeria. They are also yellow. Ghana, blue. At least they have black star, and now they have a blue forms. Yeah, so that forms is there, but less incident reporting has been observed, and probably is related to the culture of our people to report many things, including the adverse drug. But there are several episodes that it has been reported, and the medications were retracted from the market. And therefore, at this particular point, a low-hanging fruit is to advocate more and increase the voice from the patient perspective. At least they can increase the voice and report and report and report and report. Again, on that particular safety, we looked at, it was about IPC, infection prevention control. We were arguing that it's a problem, and I think we need to take action, and it's very important that it was included in the strategic plans. And what we're experiencing is there are several issues that are related to attitude of the healthcare workers. We don't wash our hands so often, despite being taught that wash your hands before eating and before moving from one, before touching another patient. I don't know where is the fault. Maybe we need to do a fishbone analysis to come with data that will help us to really look at it. But we looked at it in terms of processes. We have prophylactic antibiotic policy in surgery that you should be giving it 30 minutes before 1 hour to 30 minutes to 1 hour before surgery. And not every facility is doing it, but we all have the similar blanket of medications that we give. Whether you are receiving an oral surgery, or you are receiving a cesarean section, or you are receiving a ORIF for your broken leg, we will all receive the same blanket of medications most of the time. And here the low-hanging fruit is to stratify procedure and antibiotic therapy that you need to do depending on the hospital antibiogram profile that have been researched. With all due respect, if I've forgotten something, you can remind me, and if you want to add some more things, we still have a few seconds.
Thank you so much, that group. I like the infusing the self-care, family care into clinical processes, yeah? Yeah, patients reminding clinicians on what to do if they've forgotten, and some of the care processes that can be done by the family, for example, 2-hourly turning of the, patients, stuff like that. So next table, maybe next to you.
Yeah, as we
Dr.
go to
Lydia.
the next table, I listened to them, and I think they had a lot of things that would jump to table 4. Others that would jump to, if there was a table 6, the ones for reporting. Yeah, so there's a lot of family patient-centeredness in their discussion. So let me see how, if your neighbor has some of your answers, how do you outshine them? Because now number 4 is really patient and family engagement. Yeah, let us hear.
So thank you so much. We were looking at patient and family engagement. So 4.1 was on policies. So we realized so much has been done at the national level in terms of policy development. But in terms of implementation, we realized that we still need a lot of engagement so that these policies are not just written in documents, but they're actually being implemented at all the levels, all the way from the facilities to the national level. We realize that also engaging patients by also ensuring that we have the service charter, so it's detailing what are the services being provided, are they friendly to the patients, is it what they actually need, that will be very good. We also realized that in our discussion that the patient involvement is very minimal in terms of the patient advocates. It's usually the healthcare workers that are making the decisions, making all the decisions that need to be made, but now we need to involve the patients and have them as advocates. One of us mentioned that engaging them in the various committees so that they actually give a voice on the patient. We actually have patient advocates in our various committees so that we know they're given a voice. Then on community-led monitoring, we agreed that having the community participate in monitoring these patient-centered approaches and engagement we are using is very critical, which may not be happening as it is. Also, the institutions and also various stakeholders can give health talks to the patients and to the community so that they actually get to listen to the patients. What are they saying? What are their needs? And then on feedback and action plans, we can, through use of surveys or other mechanisms of getting feedback and actually using this feedback to develop action plans and improve patient care. Then we also looked at patient literacy. How do we ensure that patients are educated on their rights, on what they are expected to have when they come to the facility? We have to ensure that there's a lot of deliberate choices being made into ensuring that these patients are educated through various ways to give them this education. Then finally, there was a lot of emphasis on use of digital technology so that we can actually get the patients to give feedback and their views, and they get to participate in their care. Then training of healthcare workers so that they actually involve the patients in decision making. We realize that most of the healthcare workers, they don't engage patients, so we can make deliberate decisions to actually encourage healthcare workers to communicate with the patients at the bedside and let their voice be heard. I hope I've mentioned everything. Thank you.
They've done a great job. I think theirs can fall in any of the sections. In the last World Patient Safety Day, the theme was patient and family engagement. And I know as a continent, we quite expounded on it. There was a tool from WHO that was called What If, that we enable patients to ask. For example, if I'm going back to theater for a second procedure, it is possible I have questions. So healthcare workers to give patients the words. So they are taught to use what if. Yeah. What if you washed my hands? Would my child have gotten sepsis? What if we went theater yesterday? Could we be alive today? I mean, just those are difficult conversations. So let us look out for that tool called What If. What if? I know it is from a surgeon. I'm also a cousin of a surgeon. Gynecologists are surgical medical. So the What If tool, surgeons are put on the on the blame, but you know what I started with? Washing hands. That is for everybody. What if you washed hands? And in some places, they even help the patient. There's a quality improvement approach somewhere whereby the patients were telling the doctor, thank you. After you leave the room, thank you that you washed your hands. And what if you did not? You would be told. So empower the patients to remind you, I'm happy that you washed your hands before touching me. You're empowering the patient. So there's a lot of interesting aspects of patient and family engagement that help safety to happen consistently in healthcare. So let us be bold, let us be vulnerable to try them. We'll be hearing tomorrow from Benta some of these things on patient engagement. I cannot leave that table without being excited about how humbling it is to keep learning from the patient. There's a patient who told us after we talked to her, so she said, oh, so you want to tell me in the ward they take care of me and I come here, you listen to me. So the patient was telling us, our motto for the hospital is we listen, we care. So the patient was telling us, oh, that motto I think should be together. The people who are caring should be listening. So you should listen and care. You don't separate. That the customer care person goes and talks, and me, I give you the injection. Give me your whatever, I push the injection. We need to communicate. Even patients who are moribund in critical care, those who've come out of that phase, they say it used to be very scaring just seeing people come. Suddenly, there's something in my butt, there's an injection. So you need to talk. That is patient engagement. Number 5. Okay.
Hello, everyone. So on behalf of Table 5, so from South Sudan, Cameroon, and Kenya, allow me to present what we have discussed. So we were talking about what is the framework for action to inspire, educate, capacity build, and protect every health worker to contribute to the design and delivery of safe care systems. And we've heard in Cameroon from Dr. Nora that, yes, she thinks it's something that should be highly incorporated where she comes from, because it's one of the things that is not correctly done. And we also felt in some of the other regions on the table that yes, this is a place where we are also lagging behind. And Joseph from South Sudan over here said, patient safety is overlooked and much attention is paid to the professionals. So it kind of felt one-sided, and the patients also need to be taken care of. Not just the healthcare professionals being trained and told what to do, and the patient also not knowing what part they play. From Bernard, we had that most institutions have protocols, CMEs, that can be integrated into patient care, but sometimes that is not paid attention to. And quality improvement was also mentioned, sometimes not to be present at the beginning of training. So people go through school, quality improvement on and even patient care sometimes is one of the things that people will go through school. It is just talked about, but only practiced when you leave school. And from KNH, yes, they have had webinars that have been made available, and majority of the healthcare workers have joined, though we still have a gap where we do not have a structured curriculum on quality improvement and patient care. So you will find different institutions have different ways of doing it, but if at a national level we had a uniform way of patient care and quality improvement on the same, then that will be appropriate. We also spoke about, are there centers of excellence when it comes to inspiring and educating the healthcare workers? And Bernard here mentioned, yes, he has been in places where there is, like in Uganda, there's a regional center for quality healthcare, but in our nation, he has not found any or seen any. But we have heard from KNH, there's a department for patient safety, yeah? And if at all, other institutions can also borrow a leaf from an institution that is already doing it. Just like we were told this morning, it is good to copy, don't be ashamed to copy, but also give credit where you get this kind of knowledge from. And when it comes to the fourth one, which was linking patient safety with appraisal system, it is possible, yeah? It is a low-hanging fruit. But then we saw an image this morning where there were records and files, some on the floor, yeah? So you can imagine going to look for a file which you do not even know where it is sometimes. So appraising that and actually making it known that yes, you can link a file and what someone else did. And we even saw some files that were missing, right? And others duplicated. Then it becomes really hard if the system is not working in the correct manner. And finally, safe working environment for healthcare workers. Much of it is done on an individual level, where we felt I might actually be doing something correctly, but then I am probably the only person who is doing it on my floor. Yeah, so it is not really a collective responsibility, and if at all people owned that patient care, patient safety is something that starts from an individual level. It's not just about we have to do it as a group. I have to start, you have to do it, then the goal of patient safety can be met. Thank you.
Thank you very much. I think they have done well. Peter, allow me to say number 6 and 7. 6 is on health, on information technology and incident reporting, and how just to use digital health for patient safety. And so those medical error reporting systems having decision points that, what is it called? Enabling AI to support safety. Yeah, it's part of that. And number 7 is on partnership. So we are here to form partnerships towards patient safety, and different kind of partnerships at multiple levels, up to including patients and community. So I think this was an introduction and entry to that action plan. I hope that the document, in case somebody needs it, they could ask Secretariat. Will share the Global Patient Safety Action Plan. And so, Peter, we've done 1, 2, 3, 4, 5, 6, 7. You can proceed. Or rather, maybe an applause for everybody.
Thank you. Thank you very much. So I really appreciate the conversations and the time that you spent on them, and the commitment and the whole mix of it. So I know tomorrow will be another rich day. But before we draw the curtains, I just want to invite Ruth Pal to make some announcements and close the day. Thank you.
Applause for Peter Mulanda. He's done a great job with the time. Now, are you following us on Twitter? Are you in the WhatsApp group? How are you going to keep up with what's going on? I want to acknowledge Saiton at the back, who's doing a good job of documenting, and Amos and his team. You know, we've put them all in the Google folder. So you have access to photographs from today, all the presentations, speaker bios, you have it all. So are you following? That's the first question I'm going to ask. Okay, so what to expect tomorrow? Why should you come tomorrow? So we've been talking about why should you come tomorrow? This is an important question. We need to know whether you're coming. So we've been saying, how does quality happen in facilities? How does it? We are going to hear from Kenyatta National Hospital, Kijabe Hospital, who have done a very good job in building a critical mass of quality improvement champions and leaders in their hospitals. So we'll be hearing from those teams tomorrow. We'll be hearing about patient-centeredness, and of course, we'll be hearing from the gurus of them all. We have the CEO of Ubora Institute from Ghana here, so expect that tomorrow. And then we will spend the other half of the day talking about leadership. How are we going to get this happening if we don't lead? So we'll talk a little bit about leadership, have some reflection. We have Professor Bukusi coming and so forth. And then we'll conclude the day by action plans. Our 2 days here, of course, you know we are people who turn things into action. Acquire wants to work with you. I think that is we've used it as our tagline for a long time. Acquire wants to work with you. So what is it that we can work on together? How can we build this community of practice together? That is one reason you can come. The second reason might be because you want a transport allowance. They'll be being given out tomorrow, so maybe come tomorrow. If you saw in the logistics note, that was a promise that we made. There's also going to be a lovely branded gift for everyone who shows up tomorrow, so that's another reason to want to come. I'm giving you multiple reasons. Now, we've not had a chance to get to know each other, so we set up a dinner for all of us today. It's on the second floor. We want to start at 6 so that we don't stay on too long. And it's really a chance for us to get to know each other. Our intentions will be everything informal, storytelling, laughter. We just want to get to know each other. So please stay, if you can, just for another 90 minutes so that we can have that sort of getting to know each other. That is what is happening immediately after this. Is there anything else I've forgotten, Shiro? All the presentations are in the Google folder. If you wrote, if your breakout group typed or wants to type, if you paste it in the WhatsApp group, I'll put it in the folder immediately. We are all about efficiency. Again, where is the Google folder link? It's in the email that was sent to you. By the way, those emails, all that communication has been by the wonderful Chiro Olande. She's the lovely lady in red. She's done a very good job bringing us together. So, are you asking me what WhatsApp group? Go back and look at the email she sent. What Google Drive link? Go back and look at the email she sent. Okay, so am I seeing you all for some fun and laughter in a few minutes? Please stay on. Let's get to know one another. See, tomorrow we start at 8:59. So we've already established. Before 9, we will be started. See you tomorrow, and thank you for making the time to come. Do you want me to sing the national anthem or? The venue of the restaurant is the second floor. Let me look for the name of the restaurant again. Baluba. It's on the second, so the same place we were eating essentially. Yeah.